All right, can you all see that?
Yeah, we can see that. Thank you.
Okay. So today we're going to talk about sort of the cool but very complicated world of genetics and psychiatry, and how it might impact actually a clinical tool that's on the market that I think people know about, but we're going to do a deep dive into sort of what this is. So we're going to start with just reviewing some genetic terminology, and how sort of complicated this is regarding psychiatric illness and treatment. This very specific idea for pharmacogenetic therapeutic drug testing is really what we're going to kind of to dive into, and some of the factors of what those types of testing look at. And ultimately, this is a clinical talk, so we really want people to have an understanding about what this tool actually is, how to use it, how to choose wisely, how to like actually take a case. And we're actually going to pull out a case that actually is a real case that I was part of, to look at, in sort of all the good, bad, and ugly of what it was. As a disclaimer, I have no ties to any of this testing in any way, shape, or form, but and I do support it, and it has been helpful to me, but I think it's really helpful to inform yourself of the limitations of testing too, and what it's not. And I would say at the end, this is a tool that we want to know how to use, but use wisely. And so I hope throughout today that I translate that knowledge to you. Um, so I think the first real challenge to realize is that, psychiatric treatments, diagnoses, and treatments feel very subjective to people. There is no test, there is no imaging study, there is no lab that definitively defines any psychiatric diagnosis or treatment protocol. And that is inherently frustrating to not have clear, defined black and white. And that is kind of inherently the challenge here, that this test does not answer either, that we talk about, but is part of what kind of drives the continued quest for objectivity, I would say. Right now, the only mental health diagnosis that requires some degree of testing is that for intellectual disabilities, through IQ testing. Every other diagnostic criteria does not actually require a test. And so it's important to always remember that psychiatric diagnoses are validated, they are evidence-based, but they are clinical diagnosis based on clinical recurrent interviews, mental status exams, symptom tracking, often over time. And many of our illnesses are chronic and episodic, and there are limitations to testing, just inherently because of the course and nature of our illnesses. And what this means, because of some of that chronicity, is that it is frustrating to people that treatment becomes a very trial and error approach. Sometimes it feels like when, for people that are suffering. Whoop, that I just really screwed up. Sorry, wrong button. Um, and the other challenge is many of our diagnoses and conditions are heterogeneous. Every patient story is different. If you look at like depression, there are nine clinical variables and different time frames. And at the end of the day, I sincerely think every story of depression is different, and every treatment plan for depression ultimately is different and individualized. And so that's a challenge when you're looking at treatments and medications too. And we don't have reliable biomarkers that predict illness, or predict response to treatment, despite all the genetic studies and attempts to isolate singular causes. We don't have, if you have this, you get this type of things. These are messy conditions that often impart multi-variables, and genetics may play a role in that mess of variables that contribute to outcomes. But it also plays a role, it does play a role to some degree in how people metabolize the drugs. And that is where the target of some of this testing has come. And then, no one is patient. The other challenge with this is that all the treatments, at least from medicines, typically take 3 to 6 weeks, especially for mood and psychotic disorders. Maybe a little faster for ADHD and some treatments, but it's not a quick response. You don't get better or feel the effects tomorrow. And so it lends in other variables in response patterns as well. And all of this in terms of providers and patients leads to frustration. People don't want to stick with treatments. They don't follow things forward. We have unnecessary suffering, and sometimes people don't continue to progress with stages of treatment because they're having side effects or other ramifications from the treatment. It's kind of like chemo, right? The treatment causes you to feel awful, even if the end result is a better response. And so all of these things really lead sort of practitioners and patients wanting a more, well, how do I have a more individual approach that the first thing I pick works, which is kind of ideal. And so I think it is in this space that some of this has emerged. So there have been many attempts over time to identify singular ways of identifying biomarkers. There have been behavioral studies, psychiatric, psychological studies, imaging studies, genetic studies to really try to identify reliable biomarkers at both diagnosing and treatment responses. And these are just a few that have looked at depression. And the answer is no one's found the shining, sparkling bullet answer of one singular response at this point. So we have arrived at a sort of understanding some of the terminology regarding genetics. And so when we talk about the role of the drugs and looking at drug and genetic interactions, that is really this realm that these tests sort of fall under. And so pharmacogenomics is how our genetic makeup or variations in our genetic makeup or person's responds to a particular medication. And then that is broken down further into these very key terminologies to understand. And that is pharmacokinetics and pharmacodynamics. Okay. And I'm going to show you examples of why we're doing it. So pharmacokinetics is essentially what your body does to metabolize the drug, how your body reacts to the drug. Okay. So each person is going to swallow a pill and it's going to get processed in a certain way. That's pharmacokinetics. Okay. Pharmacodynamics is not about how your body processes the drug, but as the drug is released, its mechanism of action, how your body responds to the drug. If we can keep those terms kind of separate, because the tests are kind of looking at those two factors. So those are just very key terms to help guide us a little bit. Again, so pharmacokinetics, what your body does to the drug, and pharmacodynamics, what the drug does to your body. Okay, those are some key sort of things to understand. Okay, this is not a genome-wide association study, and this is also where I am going to tell you I am not a genetics expert by any means. Genetics is incredibly complicated. I subscribe to genetics for 101 for dummies in how I understand this, but I think it's really important to make sure that no one thinks this is in any way, shape, or form. These types of tests are not related to specific genes, okay? Because psychiatric illness has never been linked to one singular gene effect. Okay. And that's again is challenging. We have genetic syndromes, we have predictable patterns medically and may have psychiatric components, but there has never been a single gene study that contributes to any specific psychiatric illness, like with full-on effects. And so when we think even about the heritability of depression, and it is very heritable, right? There's well-known passing of genetic traits. If you have this many family members affected, you are at risk, but none of that has ever been explained by a single gene. And so when we talk about single specific genes, that effect is very small and is really not part of this conversation, but it's hard to not want that and for people to get confused when we talk about genetic testing, because we're not testing your genes in that regard. And I wanted to just sort of make sure people really know what these are looking at. And people have tried to do this with the genes. So these are all studies that were sequential treatments of depression studies, and they tried to go back and look at the genetic outcomes of how people responded, and they couldn't find anything, at least in this genome-wide look. And so those are kind of retrospective look backs, and we still weren't finding anything. So we've not been, again, this magic bullet, even of people that have responded in ways to go back and find out why. So we still have not made that leap. But that does not mean we have not made progress. And this is a really wonderful website. It's sponsored by a lot of research entities, but it's really a comprehensive source for people to know what exists in the realm of genetic variations and drug response. And this is actually, mental health is actually a very small part of this website, but I wanted to share this with you. It actually has a ton of information, especially regarding cancer treatments and a lot of other sort of things that have also occurred. So this is kind of a one-stop shop if you really want to go and get some definitive information, but it is very broad. But it is from some of that site that some of this evidence stuff comes back. So we're going back to that idea, right, of pharmacogenetics and how the body handles the drug. And so we get into terms of how is the drug being processed. And so when you swallow a pill, it's either going to get metabolized by the liver or the kidney. Most drugs go through the liver, and there are very specific enzymes that might process the drug. And each drug has its own pattern of how it is metabolized. And then what happens is, and these are the terms that comes across in terms of how it is metabolized, you will see labeled for the specific enzyme. And so this is how the reports end up looking. You have terms like, you are a poor metabolizer, meaning you do not handle this drug very well at all. Your body is not breaking it down. You're not processing it. It may stay more of its whole form before it gets cleaved through the liver. You just do not handle this medicine as we would expect. Intermediate metabolizers, somewhere in the middle between poor and normal, meaning you kind of handle it okay, but not like it would be normally. And then this is the tricky part. They call it extensive metabolizer. That actually means a normal metabolizer. You handle this medicine the way we think your enzyme should have handled this medicine. And then the ultra rapid metabolizers, you handle this medicine so well, you process it so fast that you actually lose the activity of the drug because you process it faster. Okay. And so those are kind of the terms related to how these liver enzymes, these CYPs, the cytochromes in the liver, are going to get laid. And we're going to talk about what those are, but that's kind of the terminology. Okay. So poor metabolizer, intermediate metabolizer, your extensive, which is your normal, and then your ultra rapid means you're processing it too fast, too well, kind of dose.
Dr. Swagger, can I ask you a question?
Yes.
So when you talk about the liver, but you're talking about genetic variation, right?
Mm-hmm.
Does
in
that
the enzyme that processes the drug.
Okay, so it wouldn't matter if you, like somebody with cirrhosis compared to somebody with a normal liver. Is it assuming everyone's liver's normal?
Well, it is similar, but not the same. So when you have things like cirrhosis, large quantities of the actual organ are affected. And so what you often see is processing changes related to multiple variations of the enzymes not working or not being present. So you can still have metabolizing problems, but they're more global than specific to an enzyme. Does that make sense?
Yeah, that makes sense.
Okay. Great question. So again, there are a lot more liver enzymes than this, but these are 5 enzymes that have lots of evidence and are kind of considered moderate to high evidence of enzymes that clearly have more evidence that they impact drug processing than others. And so these are 5 of the ones you see. Now the bottom 4 are the CYP are 4 CYP enzymes, right? So you have your IA2, your 2B6, your 2C19, and I think I left off the 6. I think it's 2D6. I screwed that up. I'll fix that. But those are 4 seriously major enzymes, but they do have clear genetic sort of linkages to how they process. And then the ABCB is a glycoprotein that sort of codes part of the processing through a different mechanism. But these have lots of good evidence for them to know how they're working or not, and how they're metabolizing. And many of those four are, and there's some data, like almost 90% of all drugs go through 6 enzymes. So these are 4 of those 6 that are very prolific. And I will say, and this is really important too, as we talk about the tests, is these tests that are sold as psychiatric tests, they give you information that is going to impact other medications that they don't test for. And this is an important translatable thing to people. If you find out that you are a poor 2D6 metabolizer, and these are the drugs for you or not for you and how you handle it, that information might be relevant to a cancer drug. That information might be relevant to your blood pressure drug. So even though that the test didn't look at those things, that's still really helpful information that isn't necessarily going to change, that we don't want people to lose either. These are not things that are just psychiatric things, even though that's how the tests are. So let me say that as well. So these are those pharmacokinetic ones. Okay. So the next one are those, what are the pharmacodynamic genes that impact things. And again, so this is how your body responds to the drug. Okay. And this is looking at the things revolved in the mechanism of action. And most of our theories about the etiology of psychiatric illness include things like neurotransmitter pathways. Those could be the dopamine, the serotonin, the norepinephrine pathways. It could be related to your stress and cortisol response. So you'll see those markers on there. You'll also see things about inhibitory or excitatory things like GABA, or that might get affected. And so when you see all these genes, and I'm going to show you what their names are, you'll see that they're part of the theory of the role of etiology. But again, they're just a protein in the pathway of very complicated processes of how these drugs might target things. So and these are the little codes: dopamine, norepinephrine, and serotonin have these little DA, DE, 5-HT as sort of their markers. So we're looking at genes now that aren't processing in the liver, but genes that might be encoding things along how that mechanism of that action of that drug works. So if you have a problem processing serotonin, or your serotonin transporter isn't working, you may struggle with a drug that works by a serotonin mechanism, is the short version of that. Okay. So these are some of the pharmacodynamic tests that have more evidence for them. And you'll see things like that the ADR A2A involves alpha-2 adrenergic receptors. So that's your adrenaline response system, right? Sympathetic tone. You'll brain-derived neurotrophic factor is actually like a growth factor of support for neuronal health. Again, it's more complicated than that, but that's just looking at sort of neuronal factors in general. The COMT enzyme is an enzyme involved in the metabolism of catecholamines like dopamine and norepinephrine. You'll see the CRHR1 is corticotropin. That's a stress pathway. You'll see the FKBP5 encodes proteins around that glucocortical stress response pathway. And the GRIK4 is part of glutamate. Glutamate is a super excitatory neuron that causes these ion-gated channels in the excitatory pathways of the brain. The next 3 here on, the next top 2 on here, the HTR1A and 2A involve the serotonin receptors. And you can kind of see there's serotonin receptors that may involve like the passive coping pathways of anxiolytic effects. The 2A receptor sort of involved in more the cognitive flexibility, symptomatology pathways of serotonin. And then these last 2 are kind of talking about transporters. So this is the norepinephrine sodium transporters. And then the bottom is the serotonin transporter in how serotonin is taken across the membrane of the neuron. And again, that's sort of a functional piece of most selective serotonin reuptake inhibitors. If you can't pull your serotonin in or out of the channel, synapse very well, it could impact what you would expect it to do. So all these genes, and you're going to see in this report all these labels, but they're really referring back to these specific parts in a very complex pathway. So I'm gonna pause there because this is this is like alphabet soup, and I really want the concepts of it to just be understood, because I think this can be very overwhelming. It's certainly very overwhelming to patients when they see these reports, but really all of these things are part of our theoretic and sort of our global sense of all the possibilities that impact expression of depression or psychosis or mental health pathways in general. Is everybody with me? Okay.
Yes.
All right. All right. So what does that mean for these tests? Okay. So I'm going to show you a GeneSight report, and that is just completely because that was my experience clinically, was using GeneSight, but it is not the only one. There are many companies out there that are trying formulations of these. All of them have select differences in which genetic, pharmacokinetic, or pharmacodynamic markers they're using. The ones I showed you were the ones with the most evidence base, but all of them to some degree use different ones and have different profiles. But those are the ones that have the most evidence for being linked to drug response. And many of these companies are doing their own research to look at biomarkers and comparing things. And so you'll see on their websites a variety of things they've tried to enroll to perfect their tool or their test. I do want you to know, and this is something, you want to be aware of. I mean, these are for-profit companies. They really want you to use their test. It's kind of like drug companies, right? They want you to buy their product, and they're gonna give you all the good stuff and all the information. But it can come and really look like a high-pressed marketing campaign a little bit. And if you don't really understand how to look at it, I think there's a tendency for sort of bias and to think it can do more than it could. And so I always, you always want to have a healthy dose of skepticism, or at least I do. I do find these tests really helpful. But if you talk to people, I think sometimes people think that it's a magic solution to all things. And I say that because I have had patients come to me saying, I want this genetic test to tell me what drug will help me the most. And it can't do that. And we're going to talk about that a little bit more. It can absolutely not do that. But in the marketing, and these are direct to consumer and direct to provider marketing, that message comes across repeatedly to people and clinicians and patients. And I again, it's a very, very helpful tool. I think it's been critical to a lot of my decision making, but you have to still choose it wisely for the right patient, or it won't help you. So this is really about, how do I use this tool and what can it really do and what it can't do, that we're going to drill into a little bit, because it's messy. And if you look at some of the research, there's questions about, really, I mean, randomized control trials are great, but these are very small samples. We talk about how heterogeneous the conditions are. Many of them are not large enough to probably see the true effect that we want to see, for how diverse our illnesses are. And there's definitely conflicts of interest and the question of cost. And again, I cannot speak for many of the things. I actually frequently talk to the GeneSight people. I don't even know if it's accurate. It's probably like 2-year-old information, but it was $1,800 that they would bill insurance for the test. And it was, I think, $330 out of pocket if the insurance didn't cover that. That was ultimately what they were asking people to pay. And you know what? That might be totally reasonable. But again, I think it kind of comes down to how that, like, let's really talk about how helpful that test is going to be. And then my answer to you is, if you get this test, don't ever lose it. The test would not change, and you don't need to keep repeating it. And it may be important for other things. So, I mean, I think it's just really important to know, okay, which patients is this going to help? What things do I need to think about before I order it? Okay. So what are the people that it might help? So One, and I cannot say this enough, these tests make no diagnoses. If you have no idea what your patient's diagnoses are or the etiology of their condition, do not order this test. It will not help you. And I cannot say that enough. It will not tell you what's wrong. It doesn't tell you anything about diagnoses. It is literally a list of medicines and how you metabolize it when the report comes back. And because again, we want it to be more than it is, right? We want that answer, that easy answer, but it's absolutely not. And I cannot tell you, and again, I live in a very specialized world of complex kids. I cannot tell you how many people came to me asking for that test. I need to know what's wrong with my child. Nothing worked. And I would literally sit down, I think your child had the wrong diagnosis. I don't think any of the things you tried were actually ever going to be helpful because that wasn't what the problem was. And we can talk about what that means, but this test has no realm in helping you get the diagnosis right. If the diagnosis is wrong, you got to go back to the drawing board and really reconsider that because there's no place for that. It also does not say that one medication is more efficacious than the other at all. So, and I'm going to show you an example where, they'd tried many different medicines, but if it still doesn't help the medicine work faster, it still doesn't help the medicine, if you haven't tried it, you don't know if it's going to work. You still needed 6 weeks or 3 weeks or however long you needed to see the response, okay? It does not help you say, this one's going to be better than this one, okay? In terms of making my psych symptoms feel better, it doesn't do any of those things either. And so it is helpful to know what you've tried and what hasn't worked and what or side effects that you have, but it just doesn't answer that question either. But it does help with some things. So that's what we're going to mean. It may really help understand side effects, okay? And this is a huge piece of, I think, where it has been helpful. Because remember, we talked about how you process that drug. So when you have somebody that has had very bizarre or excessive side effects at doses you wouldn't expect those to normally happen, so maybe they're processing it differently, or you've had them on full doses and they've had no response, it can really kind of help you I wonder if they're processing it too slowly, or I wonder if they're processing it too fast. It can really help with those types of things. It can actually really inform dosing. I've gone to the maximum dose of this medication and the patient has no side effects, but I haven't seen anything get better. Is that because they're not going to respond or something else going on? So I do think this test can be incredibly helpful in that for those types of patients. Okay, so I'm going to show you a sample report, and I've tried to block everything out, but please consider this HIPAA-like, even though it doesn't have information on it. So this is a report, and I'm sorry, I cannot remember the child's age. It was a teenager, and her diagnoses were schizoaffective disorder, ADHD, and conduct disorder. All right. And for the child people on this call, we don't even need to start how I had 300 questions about whether those diagnoses were right. And we'll leave that for another thing. But the reason the test was submitted and the reason I was asked to look at it, and I'll read to you what was submitted on the report. The following medications have failed to work for this patient: lithium, quetiapine, Risperdal, and Zyprexa, right? All medicines that might be treatments for schizoaffective disorder, okay? So this was submitted as treatment refractory response to improve schizoaffective disorder, okay? From 3 antipsychotic failures and 1 lithium failure, okay? All right, so I'm going to tell you, if this patient really had a thought disorder and this patient was really psychotic and they had not responded to 3 appropriate trials of antipsychotics, 100% this may have been really helpful. 100% if they had had odd side effects at appropriate doses, this could have been life-changing for this patient, okay? But this is how it was submitted. And the thing is, the reports are all very much the same. So can you all see the report? Okay, so this is the GeneSight report. And again, they're presenting, this is like 15 pages. And so when you go to look at a report, you also have to understand what you're looking at. Because this looks really pretty, right? This has green, that looks like the stoplight, oh, safe and wonderful, it's great. Yellow, caution, and red, no, right? The stop sign, red. That's not actually what it means, okay? So I mean, the colors are beautiful, but I really want you to understand what the colors represent. The green actually says use as directed. So the green columns in all of these mean take those FDA guidelines for how you should dose them normally and dose them normally. You can use the one in green as directed. That means use the appropriate doses for their age and weight and expectations, okay? It doesn't mean this medicine will make you better, because I promise you, none of you probably want to take any of these if you really don't need to anyway. And so it doesn't mean that we're all going to get better with this list, or this patient needed. Again, this patient probably didn't need Elavil. That is not what it said. It said that this column, and this is the antidepressant column, and they run every psych drug they can think of against this profile. So you get 15 pages of just how all the psych drugs respond to their profile. Okay, so the green is as directed. So I would dose it. I would let the time relax normally. The yellow column has moderate gene drug interactions, okay? Which means there is probably some way that the processing of this drug is being affected, or the pharmacodynamic properties of this drug is. So what it means is you might have to change the dose or how you give it, okay? And you can't really know that from this one unless you look at the number. So if you take Wellbutrin and MSAM from the yellow column, you go down to the one, it says serum level may be too high, lower doses may be required. And probably what that's going to mean, because then this report gives the same information to you 4 different ways, and I'm going to show you how to read that. It probably means that the enzyme that metabolizes that drug is probably either a poor or an intermediate metabolizer, okay? Or if we look at 4, okay, so 4 is Celexa, the Lexapro, the Luvox, the Paxil, the Prozac. Those are all the selective serotonin reuptake inhibitors, right? And there's a 4, and we go down in 4. The genotype might impact the drug mechanism of action. I'm going to guess that probably the serotonin transporter, or one of the genes that's impacted in that serotonin list, probably isn't processing and interacting normally. And so it's going to impact the entire class of drugs. That's my guess, okay? And we're going to see that a different way by the actual enzymes later on. But that's where this report comes from. In this one, there's no red, but the red column will say the same thing. And just so you know, typically the really poor metabolizers end up in red, and the moderate ones were the intermediate ones, or how many drugs interacted on that pattern. So if you had both a pharmacokinetic and a pharmacodynamic effect that was synergistic, you might see it move to red, okay? So the columns come from the interactions with the test, okay? But that's how you do it. And you can go through each report, and they just do the same thing. This is these are all your benzodiazepines that they're running, okay? And it's only the Valium that had, again, serum level maybe too high. And then they run through all the antipsychotics. Now, mind you, remember this patient had 3 antipsychotic trials in lithium, and those 3 antipsychotics are on here, and it's telling you her body was processing them normally, okay? So if anything, if you're going to take that clinical information, it wasn't that the drug wasn't being metabolized or processed as the reason it failed, okay? That's our clinical takeaway. She was not treatment refractory to those medicines because of a gene drug or interaction, okay? So it does inform us about those trials, okay? And then we have our mood stabilizers. Again, in this packet, they actually do not run tests on the Neurontin lithium or Topamax. So the lithium our patient took This is not a test that's looking at any markers affiliated with those. And they also run stimulants as well. Okay, so that's the color schematic part of this, and then it moves into looking at it through other ways. So this is more of the descriptive examples, okay? So again, this is the genotypes and the phenotypes. You see all these letters, these should look familiar to you. These are that alphabet soup I gave you of pharmacodynamic genes, right? These are the pharmacodynamic genes. And they're telling you for each of them, you'll have a normal response, or this is normal, this is normal, this is normal. This one right here, that was one of the serotonin transporters, that's a reduced response. And that's why it's going to impact that entire class of the selective serotonin antidepressants we saw in the fancy yellow at the beginning. Okay. And then we get into, these are the pharmacogenetic ones. So these are your CYP enzymes. These are some other ones this one runs that doesn't have as much evidence, but you see it again. This is normal, normal. This is intermediate. This is normal, intermediate, normal, 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 normal for the enzyme. Okay, and then they also run COMT. Okay, so that's part 2 of the same information. Okay, part 3 is now they put it in a table. So you can look at all these are your these are the pharmacokinetic ones, the liver enzymes, where they put it by enzyme. So you can see here, because this was an intermediate metabolizer, all the drugs that are under that 2C9 are impacted. So any drug that goes through this would need a reduced dose. And so it's just the same table, but leading with the enzyme instead of the drug categories, okay? And it goes through all the same things that were in the first one. Okay. Too fast? You want me to go back and look at anything?
I think going good. We do have a chat in here. I didn't know if
Okay.
you wanted to wait.
I cannot see the chat, so if you
Okay,
can read it to me.
I can read it to you. Okay, so if, for instance, a kid has ADHD, which was a correct diagnosis, and we're trying to find a medication that is most efficacious, then this assessment wouldn't be so good. But if we tried Adderall and it seemed to work after 4 to 6 weeks, but not as well as expected, or a side effect is more severe than expected, and then this assessment might give the prescriber an idea of another medication that might be more effective with a less severe side effect. Is that right? You kind of need an idea of something that is kind of working for the assessment to be most helpful. Is that correct?
I don't think it says anything about efficacy. Okay. So no, not on the efficacy part, but yeah, absolutely on the side effect piece. Like it will tell you how to dose it. So, but it may also tell you something about the Adderall. If it came back maybe that there was a metabolism issue with the Adderall, it might tell you need a higher or lower dose of the Adderall to get full effect. So it could tell you something about the Adderall. It would just tell you which other you could use, but it really doesn't say anything about efficacy. And I think doesn't say anything about efficacy. That's the challenge, is to not necessarily say it does. But yeah, you can absolutely use that. And I think it works better if you've had multiple effects too, because it's, like if you do head-to-head studies of like Adderall and methylphenidate, there's really not huge clinical differences in efficacy between those two, unless you have an individual genetic factor that impacts it or something, or and that side effect interaction might be the reason. But yeah, absolutely, it could be helpful for that. I would caution on, and I'll just say that some of those ADHD pathways on this genetic piece is actually way more complicated than the antidepressants and the antipsychotics. So for ADHD specifically, there's a whole lot less evidence of those interactions. So I know they've been pushing ADHD on the testing, but I'm just going to tell you the evidence base for this lies much more regarding your antidepressants, your mood stabilizers, and your antipsychotics. So just be aware of that the ADHD medicines are kind of complicated. But yeah, you absolutely can help you at least know how to dose it if you're going to switch to. Hope I answered that. And then here's the clinical that you submit. So I'll give you a little bit more information. This was a kiddo who I ended up talking to somebody about their medicines, and then I got a lot more information, and you know, it was helpful information, and I was like, okay, so what's going on? This was a kid when we really dug in with these diagnoses. Actually had a horrible trauma history.
I was going to ask if I could guess the diagnosis.
And you don't see any trauma symptoms. So she had experienced these things that people were calling hallucinations, but they really weren't psychotic phenomenon. They were really trauma phenomenon. And so the first question became, this really probably was not the right diagnosis. When we dug in a little bit, the antipsychotics were actually probably more for anti-aggression than for anything. Okay. And probably failed because they weren't protecting, like she was being trauma triggered in her aggression, and so they weren't doing anything other than sedating her. And actually, when you went back and you looked at what she complained about, that weren't actually side effects from a genetic perspective, but when she was sedated, she felt unsafe and was kind of fighting the sedation. And so the medicines appeared to be making her worse and sedated. Again, probably going back to the etiology not being correct. I do think ADHD actually was accurate, but complicated, because she had really significant hyperactivity. And conduct disorder, I think she'd done some bad things and hurt some people in her aggression, but again, probably coming back to the trauma piece. And so we spent a lot of time talking about this report and what you could do with it. And one, the answer was she did not have a genetic reason and how she processed those antipsychotics, but it really went back to, okay, let's really talk about that. We don't really think she had a thought disorder, right? She really didn't have schizoaffective disorder. She did had some mood symptoms, and she had some depression, which was part of that schizoaffective piece. She had this really bad trauma and impulse control problem. And so after a lot of discussion and this being helpful is like, you know, she does have that SSRI phenomenon. So she, I think, may have tried an SSRI, to be honest, and not done well with it at some point. And that may actually have been related more to the genetic profile than anything, even though that was not the reason the test had been started. But we did talk about, okay, well, we got impulse control. We have really substantial trauma that manifests with aggression and quasi-psychotic stuff that's not psychotic, but clearly impacting her mood. We actually went and chose Intuniv for her. Could go back and look that she processed Intuniv appropriately, and there weren't any genetic concerns about how to dose the Intuniv, and I believe they started a trial of that. I actually don't know in this specific case what happened, but again, I wanted to walk you through kind of the story of the testing, because I think the test was ordered with good intent, but actually was confusing, even if it's right about why this child was failing the antipsychotics, and really, again, highlighting, yes, the test is a tool, it has value, but we really have to understand what the test asks. Okay, any questions about the report?
I have an unrelated question, so
yes.
I'll wait to see if anyone else has thoughts. So how much is this costing? Is this covered by insurance? I know every insurance is different, but.
Well, every insurance is different. And so right now there are some insurances that cover it for depression and I think psychosis. You have to, each insurance company may have their own policy regarding it. And I don't, so, and they're broad enough and it's complicated enough that it's hard to say that. I will tell you the evidence base probably requires, so this is kind of what the criteria, depending on who covers it and who doesn't, kind of look at. You have to really start, does this patient really clearly have a good diagnosis? Has there been a good diagnostic assessment? So some of the limitations on the insurance piece are, who gave the diagnosis? Was this, was this a mental health provider? I don't know, like they can be weird about that, but this goes back to the test is only as good as the diagnosis really was, right? And so, you want to be certain. And I always, I guess I'm just a creature of habit. Whenever something's not working, I always go back to, do I have my diagnosis right? Always, especially when I've tried 2 or 3 medicines, I never start thinking about like the genetic test until I answer this question. Am I really sure? And with depression, right? Like, am I now seeing a bipolar variant, and this is bipolar depression, and that's why it's not responding versus straight depression? Do I have all the information? What am I missing? Am I missing that? Like, so I always start with, is my diagnosis really right? Am I really, really sure that this was treatment failure, or did I get my diagnosis wrong? And with kids, you always have to ask that question because they can change and look so different. And so again, it's probably a little bit by nature of the kid in me that sees so many kids, but I always go back there first. Am I sure that this diagnosis is accurate? Do I need to revisit that first is where I would start. And then if you're really sure that the diagnosis is accurate, then I go back to, okay, how many trials of medicines did I really try? Did I try different classes? Did I really try it for long enough for the right amount of time? And this is also sometimes when you think they tried it for 6 weeks, but maybe they told you they never picked it up and they never tried it at all, right? And so you really, and then it comes back to, okay, did they have side effects? Did I see no response at appropriate doses that surprised me, or is it truly a side effect barrier that I couldn't increase the dose to what was the recommended? And this kind of comes back to knowing what your dose ranges are. And this kind of goes back to sort of child. I can't tell you how many people I saw that had med failures, and then dose was never increased to any range that could be helpful. Like, I would see kids on Zoloft 12.5 and it failed. Everybody's going to fail Zoloft 12.5 unless they're a poor metabolizer, right? So again, you kind of have to think about that. But if people truly are having excessive side effects, if you're truly certain about the test, this test really could be helpful. And most of the criteria it asks these questions in some regard to show that the test isn't just done out of the gate. Because what people want, and I get it, I want it too. I want to go get this test first so that the first medicine I try works and I have no problems. Absolutely, but that really is not what the test can do. And that's the challenge between sort of where the evidence lies, the cost, and our wishes for it to be that way. And I really do wish it could be that way. But again, you can see, and I have had also people bring me their results, and literally, I would like Zyprexa because it's the only one on my green. And I was like, do you have any idea what else Zyprexa causes? I see no reason in the world why you need Zyprexa, but you picked it because it was in the green column. I mean, I'm just making that one up, but I've had people come specifically asking me for medicine. And then, like, if you don't have the condition that the medicine treats, I mean, we're like exposing you to all sorts of other things. And again, I don't think people always understand it that way. So it's not a guarantee of efficacy. It's not a guarantee of anything. It's just a guarantee that your body will process it the way we expect you to process it. And again, I'm not going to give you Zyprexa if you don't have a thought disorder or severe bipolar disorder, or a true reason to have Zyprexa, because you can get a lot of other things that have nothing to do with genetics from that Zyprexa, right? There are other risks. So again, I want to have an open discussion because I know how frustrating this is for patients and providers. But again, it is just a tool. It can be an incredibly helpful tool, but pick wisely and use the tool, and then don't lose the tool, because I have had people throw it away. I've had and then I was like, okay, well, you have that. I don't know where the report is. Well, I can't order another report. Like, it's going to be the same. Like, that's an absolute waste of money. So I'll tell people, put this in your safe. You need this report. Do not lose this report. You can actually usually call the company and they'll resend you the report if you know what company it is. But again, but it is not a changing dynamic in the test, right? Your genetics aren't going to suddenly change so that you get a different report. So it really is static in that regard. And here's an article that kind of walks through that and some of the website. So anyway, I have more questions.
You have a question in the chat. It says, just to clarify, is this a test that always runs through a clinician's office, or can individuals request or pay for the test on their own?
Oh, that's a great question, Allison. So I think initially that was true. You had to go through a provider. You certainly have to go through a provider if they're trying to bill insurance, because that has to be submitted clinically and you have to get all that. But I do believe that they did pivot a little bit with that, and I do believe there's some direct availability now available if people are willing to pay out of pocket. And in fact, even during COVID, there was a pivot with GeneSight. And again, I don't have experience with the other companies. I've read about them. They're very similar. GeneSight was the one I had used. So I'm ignorant of the other ones to be fair, but they pivoted in the middle of COVID, and instead of, it's a swab, right? It's not even invasive. You take a swab and you scrape the side. It's actually a really easy test. You just twist the side of the cheek 10 times on each side and send the swab back to the company. During COVID, they actually, because people couldn't come into the office, they would do like a virtual thing where they'd mail the swab to the house of the patient with the doctor's approval.
She's like, really?
They could do it and send it back. But they were asking for the clinical for that too. But I would not be shocked, and maybe some other knowledgeable people on this call could let us know if they have experience with any other companies. I would not be surprised if they don't do it directly. I mean, they are marketing directly and advertising directly to people. And again, there would be no reason why they couldn't. And if people are willing to pay, it's so they were $330, I think, that at the time. I mean, there's no reason they couldn't that I'm aware of, unless there were certain state rules about it. There weren't like national ones necessarily that said they couldn't, but I actually don't. And that's a great question. I don't know. Does anybody else on here know about any other companies, or how much the direct is happening now? I would say it was about 50-50, and it may have changed, but about half of the insurances would kind of pay for it. Medicaid or Medicare was paying for it at one time for depression if you'd had the drug failures, but about half didn't, and people paid it out of pocket.
So I have a kind of clinical case. I'm thinking of a patient, a forensic patient that we've had who has been in state hospitals in the past, has a long-standing history of thought disorder. It's clear that it's a thought disorder. Yeah. I think at this point he's on 3 antipsychotics, which, you know, when it comes to state hospitals, they don't even want 2 antipsychotics, and one of them being Clozaril, I believe. Is that a point where you might look if he's had adequate doses of these medicine and we're adding antipsychotics and it's not touching, or is this just treatment resistant thought disorder that?
Yeah, well, it could be either, right? I mean, that's the realm clozapine enters in. So, I mean, I think if you know, that's probably a question you would ask before clozapine. You know, if you've had all these failures and you're not sure why they're not responding, or they haven't tolerated things, and it's not non-compliance, you know, that would have been a great space for this test. Maybe I didn't dose it well enough. Maybe I needed double the dose because they were an ultra rapid metabolizer to get efficacy, and they could have done just fine on the Haldol if I doubled the dose based on their metabolism. You know, would have been a good question, because you're right. Is this treatment refractory, or is it just not responding to medicine? I think that's a perfect time to answer the question. I think this is, like, personally, this would be a really important question for depression if you were considering TMS or ECT, because you'd had multiple failures and you weren't sure why. I mean, so I think that, I mean, again, this is totally my opinion, but and they do not market it this way, but clinically that makes the most sense to me to really utilize it at those points. You know, the diagnosis is clear. We've had some treatment that people are just not responding to predictably. I don't know if this is treatment refractory or something else. And to me, that's the perfect time to think about this test, especially if I'm sure of the diagnosis. I mean, I would still say with psychotic disorders, you know, make sure it's still psychosis. I mean, you can see things like encephalitis or MDMA receptor things, or weird, bizarre sort of cognitive issues that can happen even in thought disorders that can lend complexity or need to those. But again, at the end of the day, there are some people that need more than one antipsychotic, and that's just, you know, maybe necessary. And it may be that you kind of go into the, let's inform our let's pick an antipsychotic, 2 different mechanism of action, right? Maybe a dopaminergic one and a serotonergic one through those known pathways. So that we don't choose polypharmacy that does the same thing, but we choose polypharmacy that targets different pathways to psychosis as we know it. But yeah, I mean that would be a great use for this, and that's probably where I used it the most. People that either just had horrible side effects that I couldn't explain. One time I used it in a kid who was actually doing pretty well, had a stress response and took an antibiotic. He was on an SSRI, and he actually developed tardive dyskinetic symptoms and had to go to the emergency room kind of out of nowhere. And I was like, that is really odd. Like, I wonder if that antibiotic and you just didn't process it because it was just such a weird thing. And lo and behold, we did it, and he had a weird 2d6 effect that it bumped into the realm, and that's why he got this very bizarre, like bizarre tardive dyskinetic picture that landed him up in the AD for a side effect. That's just weird at 50 milligrams of this medicine, right? And so, but that was very helpful to him because it ended up impacting many things. So again, I think you can. I mean, I do really find it valuable, but I always want to have a healthy skepticism because I do think we've kind of shifted a little bit to it being more than it is, and so the goal of this was really to make sure people chose wisely and then understood the report. So.
Great. Thank you so much, Dr. Slager. I really appreciate it. And I do like that you're taking a realistic view of what it is, what it can do. I think it's very helpful because even myself, like I'm not in your guys' realm, but I thought, oh my gosh, how wonderful. Can I take a test? Tell me what medicine I need to take. So knowing what really it can do, which is still beneficial, but a realistic view is very helpful. So this has been a very interesting topic. And before you close, does anybody have any further questions or comments? All right. Well, again, thank you so very much, everyone. And the next time you'll meet will be May 15th with Dr. Kuzniar discussing best practices in family and group therapy. So I wish you all the best and thank you again. Have a great rest of your week.